Bismillah ar-Rahman ar-Rahim. Good day, everyone. Today we will discuss one of the most fascinating and clinically challenging electrolyte disorders we encounter in daily practice, which is hyponatremia. For many years, hyponatremia was approached mainly as a simple sodium problem. But today, our understanding has evolved dramatically. We now recognize hyponatremia as a complex disorder of water balance, vasopressin physiology, renal adaptation, and systemic disease interaction. I'm Dr. Mahmoud Sheikh, nephrology consultant and World Kidney Academy educator. So let's get started. All right, everyone, let's start with a quick roadmap of what we are going to cover today. First, we will go through the pathophysiology of hyponatremia, mainly how water balance is regulated, the role of AVP, and the fundamentals of osmotic control. Then we will move into classification, clinical features. We'll talk about how to approach hyponatremia based on volume status, the time course, and whether it's acute or chronic, and how symptoms severity changes management decisions. After that, we'll discuss diagnostic strategies. This includes the evolving role of biomarkers, imaging, and point-of-care ultrasound, or what's known as POCUS, in bedside assessments. Next, we'll review therapeutic approaches, starting with acute management, then chronic hyponatremia, and finally, what we do with the refractory or difficult-to-treat cases. And toward the end, we'll touch on future directions, include how AI and clinical decisions support tools and personalized medicine may reshape the way we approach hyponatremia in the near future. So with that overview in mind, let's start. Before we dive into mechanisms and management, I think it's important to appreciate just how common hyponatremia really is. This is not a rare electrolyte disorders. It's actually one of the most common electrolyte abnormalities we encounter in clinical daily practice, as we mentioned before. Every year in the United States alone, somewhere around 3 to 6 million patients are evaluated to hyponatremia. And if you look at emergency department admissions, about 12 to 20% of patients were present with some degree of sodium derangement. So this is something we see literally every single day, whether in the emergency room, the ICU, dialysis units, or general wards. Traditionally, hyponatremia is defined as a serum sodium below 135 millimoles per liter. But we will discuss later, the real clinical significance is not just the number itself, it's the context, the acuity, the symptoms, and the underlying pathophysiology. And that's exactly what hyponatremia remains, both very common and at times very challenging to manage correctly. So what exactly do we mean when we say hyponatremia? It's not really disease by itself, it's more of a manifestation of an underlying disturbance in water homeostasis. And that concept is extremely important because in many situations, the problem is not simply sodium deficiency. The real issue is we usually excess water relative to sodium. Now, physiologically, sodium is the major extracellular cation and is primary determinant of plasma osmolality. So whenever serum sodium starts to fall, plasma tonicity changes, water shifts across cell membranes, and that immediately affects cellular function. And the organ most sensitive to these osmotic shifts is the central nervous system. That's why patients with significant or rapid developing hyponatremia can present with neurological manifestations ranging from mild confusions and headaches all the way to seizures, coma, and potentially brain herniation in some severe form of presentations. So when we approach hyponatremia clinically, we are not just looking at the lab number. We are really trying to understand what's happening with water balance and osmotic regulation and the cerebral adaptation process. To understand hyponatremia, we first need to understand how the body normally regulates water balance. Under normal physiological conditions, plasma osmolality is kept within a very narrow range, usually around 275 to 295 millimoles per kilogram. And honestly, it's amazing how tightly controlled this system is. The process starts with when there is even slight change in osmolality. Specialized osmoreceptors in hypothalamus detect that change almost immediately. Once detected, the brain responds through two major mechanisms. First, stimulation of thirst, and second is release of arginine vasopressin, or AVP, also known as antidiuretic hormone. AVP then acts mainly in the collecting ducts in the kidneys, increasing water reabsorption through aquaporin channels. and more water is reabsorbed, plasma osmolality moves back toward normal, completing this tightly regulated feedback loop. So, in simple terms, for that process, the brain senses osmotic change, triggers thirst, and AVP release. The kidneys retain water, and osmotic balance is restored. And hyponatremia develops when this loop becomes dysregulated, especially when AVP secretion becomes excessive or inappropriate relative to the body's actual osmotic needs. Now, let's simplify the major mechanism that disturbs sodium and water balance. In general, most cases of dysnatremias can be understood through three major pathways, either water loss, or sodium loss, or water excess. First, water loss. This can happen with dehydration, excessive sweating, fever, or even osmotic diuresis. In these situations, the body loses more water relative to sodium, which alters osmolality and triggers compensatory mechanism. Second, sodium loss. This is commonly seen with diuretics, adrenal insufficiency, or GI losses like vomiting. Here, sodium depletion activates neurohormonal pathways, especially AVP release, leading to secondary water retention. And third, probably the most important mechanism in clinical hyponatremia is water excess. This is where conditions like sciatica primary, polydipsia, or advanced renal failures comes in. In these disorders, the body retains or ingests excessive free water, causing dilution of serum sodium. So when approaching any patients with hyponatremia, one of the key questions should always be, is the problem primarily loss of water or loss of sodium or excess water retention? Because once you answer that question, the pathophysiology and management becomes much clearer. Now, this is probably one of the most important concepts in all of hyponatremia. Hyponatremia usually doesn't mean true sodium depletion. In most cases, it actually reflects an excess of water relative to sodium. And that distinction is critical because what really matters physiologically is the development of hypotonicity. When plasma becomes hypotonic, water shifts into cells by osmosis, leading to cellular swelling. And among all organs, the brain is especially vulnerable because it's confined with the rigid skull. So the major field consequences of acute severe hyponatremia is the cerebral edema. Clinically, this is why patients can develop headache, nausea, confusion, seizures, and decreased consciousness, and in extreme cases, even brain herniation. Now, several mechanisms can lead to hypotonic state. One is non-osmotic AVP secretion, where vasopressin continues to be released despite low plasma osmolality. Another mechanism is impaired renal free water excretion, which we commonly see in kidney dysfunction. And of course, excessive water intake, especially when it exceeds the kidney's excretory capacity, can also produce the same outcome. So, regardless of the trigger, the final common pathway is the same: retention of free water, hypotonic plasma, and cellular swelling, and potential neurologic injury. Once you understood the biology of AVP, that knowledge completely changes the way we think about treating certain forms of hyponatremia. Because if excessive vasopressin activity is driving free water retention, then targeting that pathway therapeutically makes perfect sense. And that's exactly where the V2 receptor antagonist, or the Vaptans, come in. Agents like tolvaptan and convaptan work by blocking AVP activity at the renal collecting duct, promoting free water excretion without significant sodium loss, a process we call aquaresis. So instead of simply adding sodium, we are actually correcting the underlying water imbalance itself. And this was really an important shift in that field. It represents the translation of physiological understanding directly into targeted clinical therapy. Now, of course, these agents are not for every patient, and they require careful monitoring because overly rapid corrections can be also dangerous. But conceptually, they are very elegant examples of mechanism-based treatment in modern hyponatremia management. When we approach a patient with hyponatremia clinically, there are three major pillars that help organize our thinking. The first pillar is volume status. So we ask if this patient is hypovolemic, euvolemic, or hypervolemic. This is really the cornerstone of etiological classifications because it immediately narrows the differential diagnosis. For example, hypovolemic hyponatremia may point toward GI loss, diuretics, or adrenal insufficiency. Euvolemic hyponatremia raises possibilities like sciatica or endocrine disorders. And hypervolemic hyponatremia is commonly seen in heart failure, cirrhosis, or advanced kidney disease. The second pillar is time course. Is this hyponatremia acute, meaning less than 48 hours, chronic, or meaning more than 48 hours? And that distinction is extremely important because the brain adapts differently over time. Acute hyponatremia carries a high risk of cerebral edema, while chronic carries a greater risk of osmotic demyelination syndrome as ODS, if corrected too rapidly. And the third pillar is symptom severity. Are the symptoms mild, moderate, or severe? Because ultimately symptoms guide urgency and aggressiveness of treatment. A patient with seizures or profound neurological symptoms is managed very differently from someone who has mild chronic asymptomatic hyponatremia. So in practice, every hyponatremia case should be approached through these three lenses: volume status of the patient, time course, and symptom severity. Let's start with hypovolemic hyponatremia. In this setting, both sodium and water are lost, but sodium loss exceeds water loss. That leads to volume depletion, which then triggers non-osmotic AVP release and secondary water retention. So even though the patient's volume depleted, the body is still retaining water because it's trying to preserve circulation and blood pressure. Now, clinically, causes can be divided into extrarenal and renal losses. Extrarenal causes include vomiting, diarrhea, excessive sweating, high output fistulas, and third spacing conditions like pancreatitis or peritonitis. Renal causes include thiazide diuretics, mineralocorticoid deficiencies, and cerebral salt wasting syndromes. One of the most useful diagnostic clues here is the urinary sodium. If urinary sodium is low, usually below about 20 milliequivalents per liter, that suggests the kidneys are appropriately conserving sodium, pointing toward extrarenal losses. On the other hand, if urinary sodium is elevated, that suggests renal sodium wasting. And clinically, these patients often look volume depleted. You may see orthostatic hypotension, tachycardia, dry mucous membranes, decreased skin turgors, and sometimes prerenal azotemia in severe cases. And this is why isotonic saline works beautifully in true hypovolemic hyponatremia, because once effective arterial volume is restored, the non-osmotic AVP stimulus starts to shut off. Now, probably the most classic and most frequently discussed form of euvolemic hyponatremia is SIADH, or syndrome of inappropriate antidiuretic hormone secretion, and the recent name is syndrome of antidiuresis, SIADH. In hospitalized patients, SIADH is honestly one of the most common causes of hyponatremia we encounter in clinical practice. The key concept here is inappropriate or persistent AVP release despite low plasma osmolality. So the kidneys continues retaining free water even when it physiologically should be excreting it. Now, clinically, these patients usually appear euvolemic. They don't typically have obvious signs of hypovolemia or hypervolemia on physical examination. And that's why lab assessment becomes extremely important. There are many triggers for that SIADH. Pulmonary disorders or classic causes include pneumonia, TB, and respiratory failure. Central venous system disorders are another major category, such as stroke, meningitis, trauma, or intracranial pathology. Malignancy is also important, especially small cell lung carcinoma, which can ectopically produce AVP. And of course, medications are a huge contributor. Common offenders like SSRIs, carbamazepine, and cyclophosphamide. Now, diagnostically, SIADH is typically characterized by hypotonic hyponatremia with inappropriately concentrated urine and elevated urinary sodium in the absence of significant edema or volume depletion. And therapeutically, management focuses on treating the underlying cause, restricting free water, and in selected patients, considering therapies like salt tablets, urea, and loop diuretics, or even Vaptans. Now, let's move to hypervolemic hyponatremia. This is a very interesting physiological state because both sodium and water are increased, but water retention predominates. So, even though the patients look fluid overloaded, the body still behaves as if it's underfilled. And the key concept here is decreased effective arterial blood volume. In conditions like advanced heart failure or liver cirrhosis or nephrotic syndrome, the circulation sensed by baroreceptors is actually inadequate. As a result, the body activates multiple neurohormonal systems, especially non-osmotic AVP release, along with ROS system and sympathetic activation. This leads to progressive retention of free water and worsening dilutional hyponatremia. Clinically, these patients usually have obvious signs of volume overload. You may see peripheral edema, pulmonary congestion, ascites, elevated GVP, and generalized fluid accumulation. And this form of hyponatremia is particularly important because it often reflects advanced disease severity or may carry prognostic significance, especially in heart failure or cirrhotic patients. Management usually focuses on fluid restriction, treating the underlying conditions, improving effective arterial circulation, and carefully using diuretics or sometimes vasopressin antagonists in some selected patients. One very important and sometimes under-recognized causes of hyponatremia is medication. And honestly, medications review should be a part of evaluation of every hyponatremic patients, especially in elderly or hospitalized patients. Several drug classes can either stimulate AVP release, potentiate its action, or impair the kidney's ability to excrete free water. Antidepressants are among the most common offenders, particularly SNRIs. They're especially important in older adults, where even mild SIADH can become clinically relevant and significant. Antipsychotics can also contribute through dopaminergic, serotonergic effects on ADH regulation. Among anti-epileptics, carbamazepine is the classic example. It's almost broad question, famous for causing chronic SIADH. Chemotherapeutic agents are another major category. Cyclophosphamide, vincristine, and cisplatin can also induce hyponatremia through different mechanisms, including direct ADH stimulation and tubular toxicity. And of course, type 2 diuretics deserve special attention. They are probably one of the most common causes of drug-induced hyponatremia in real-world clinical practice. Finally, there are miscellaneous agents like desmopressin and even MDMA, both of which can strongly enhance water retention through AVP pathways. So whenever you see unexplained hyponatremia, especially euvolemic one, always stop and carefully review the medications list. Sometimes the diagnosis is sitting right there in the chart. One of the most critical distinctions in hyponatremia is whether the process is acute or chronic, because what really determines the danger is not only the sodium level itself, but also how quickly that change occurred. In acute hyponatremia, meaning loss less than 48 hours, the brain has not yet had enough time to adapt to this hypotonic environment. As a result, water rapidly shifts into brain cells, creating high risk of cerebral edema, seizures, and respiratory compromise, brain herniation, and even death. So acute severe hyponatremia is truly neurologic emergency. Now in chronic hyponatremia, the situation is different. Over time, brain cells began adapting by extruding intercellular osmolytes and reducing intercellular water content. That adaptation partially protects against cerebral edema, which is why symptoms may actually appear mild despite very low sodium levels. But this adaptation creates a new danger. If chronic hyponatremia is corrected too rapidly, water suddenly leaves brain cells, and that can lead to osmotic demyelination syndrome or ODS. And honestly, this is one of the biggest treatment minefields in nephrology and critical care. That's why when the duration is unclear, we usually assume that hyponatremia is chronic unless there is strong evidence otherwise, because being overly aggressive with correction can be catastrophic. The clinical presentations of hyponatremia can be extremely variable. Some patients are almost asymptomatic, while others can deteriorate very rapidly with life-threatening neurological complications. In mild to moderate hyponatremia, symptoms are often subtle and nonspecific. Patients may complain of headache, fatigue, nausea, dizziness, and cognitive slowing, difficulty of concentrating, and gait instability in some times. And honestly, these symptoms are frequently overlooked and are attributed to aging, medications, or other comorbidities. Now, as hyponatremia becomes more severe, especially when it develops rapidly, neurological manifestations become much more dramatic. Patients can develop seizures, respiratory depression, decreased consciousness, and coma, and if treated, potentially death. But one very important point that sometimes underestimated is that even mild chronic hyponatremia is not necessarily benign. We now know that chronic mild hyponatremia is associated with impaired attention gait disturbance and increased risk of falls, then fractures, and poorer overall functional outcomes, especially in older adults. So clinically, hyponatremia is not just about avoiding seizures or coma. Even modest sodium abnormalities can significantly affect quality of life and the patient's safety. Now let's move into the diagnostic approach. Traditionally, two of the most important lab tools in hyponatremia are urine osmolality and urinary sodium. Urine osmolality helps to understand whether EVPs are active or suppressed. For example, if urine osmolality is very low, typically below 100 millismoles per kilogram, That suggests the kidney is appropriately secreting free water. And that usually points towards conditions like primary polydipsia and excessive water intake. On the other hand, if urine osmolality is elevated, especially above 100, that means ABP is actively present, and that raises possibilities like SIADH, hypovolemia, and the other AVP-mediated states. Now, urinary sodium helps us to assess how the kidney is handling sodium and can provide clues about volume status of our patient. Although urinary sodium generally suggests sodium conservation, often seen in effective arterial underfilling states like hypovolemia or heart failure or cirrhosis, whereas higher urinary sodium points towards SIADH, renal salt wasting, or diuretic-related causes. But one very important message here, none of these tests should ever be interpreted in isolation, because factors like diuretic use, chronic kidney disease, or adrenal dysfunction, and multiple comorbidities can significantly alter these parameters. So hyponatremia diagnosis is never about one number, it's really about integrating lab data with the clinical pictures and our overall physiology. Now let's talk about one of the emerging biomarkers in hyponatremia, copeptin. Copeptin is a stable peptide derived from precursors of AVP, and because direct measurement of AVP is technically difficult and unreliable in routine practice, copeptin has been proposed as an indirect surrogate marker of vasopressin activity. The interesting thing is that different copeptin levels can help narrow your differential diagnosis of this case. Very low copeptin levels, particularly below about 3.9 picomoles per liters, are highly suggestive of primary polydipsia. On the other hand, markedly elevated levels, especially above 84 picomoles per liters, tends to support hypervolemic or severe physiological stress states. There is also increasing interest in the copeptin to urinary sodium ratio as a way to help distinguish SIADH from hypovolemic hyponatremia. But despite the excitement around this biomarker, there are still important limitations. There is substantial overlap between different hyponatremia subtypes, especially in intermediate ranges. So copeptin should not be viewed as a standalone diagnostic test. At least for now, it's probably best considered an adjunctive biomarker that may be complement rather than replace traditional clinical and lab assessment methods. Another biomarker that has gained attention in hyponatremia is MRI-Pro-ANP, or Med-Regional Pro-Atrial Natriuretic Peptide. Unlike copeptin, which reflects AVP activity, MR-Pro-ANP is more closely linked to atrial stretch and volume status. And that's why many investigators believe it may have stronger diagnostic utility and differentiation in certain hyponatremia phenotypes. Studies have shown that MR-Pro-ANP may help distinguish hypovolemic from euvolemic hyponatremia better than some traditional urine indices alone. In other words, it may provide additional insights when clinical volume assessment becomes difficult or unreliable, which honestly happens quite often in real-world practice. There is also interesting data from CAPNED's cohorts suggesting that combining MR-Pro-ANP with serum sodium improved prediction of short-term mortality in patients with pneumonia-associated dysnatremias. So this biomarker may eventually have both diagnostic and prognostic implications. What's also interesting is that NT-proBNP, despite being widely used in cardiology, did not show the same discriminative value for hyponatremia subtype in that setting. Now again, most biomarkers, MR-Pro-ANP is probably best viewed as complementary tool rather than a replacement or for bedside clinical assessment of the patients. But overall, it doesn't appear to be one of the more promising. It does appear to be one of the more promising emerging biomarkers in the evolving diagnostic landscape of hyponatremia. One of the most exciting developments in the diagnostic approaches to hyponatremia is the increasing use of point-of-care ultrasound, or what's known as POCUS. And honestly, this addresses one of the biggest challenges in hyponatremia: accurate assessment for volume status. Traditional physical examination alone is cerebrally unreliable. In fact, studies suggest clinicians correctly identify volume status in less than half of cases. POCUS offers a rapid bedside, non-invasive hemodynamic assessment that can significantly improve diagnostic confidence. There are three major components that are especially useful. First, lung ultrasound. We look for A lines versus B lines, as well as pleural effusions. Diffuse B lines may support pulmonary congestion and hypervolemia, while predominant A lines may favor euvolemia or even hypovolemia. Second, venous congestion ultrasound, or VEXUS. This evaluates the IVC along hepatic, portal, and intrarenal venous flow patterns. to assess systemic venous congestion, and this can be particularly valuable in complex cardiorenal cirrhotic or cirrhotic patients. And third, focused cardiac ultrasound. This helps to assess cardiac function, stroke volume, and valvular disease, and the overall hemodynamic status. So rather than relying only on a static lab value or sometimes unreliable bedside science, POCUS allows us to integrate real-time physiology information directly into the evaluation of hyponatremia. And I think this is becoming an increasingly important part of modern nephrology and critical care practice. Now, this slide shows really important practical applications of POCUS in hyponatremia. Sometimes the physical exam suggests the patient is euvolemic, but in reality, they maybe actually have occult hypovolemia, which is mean, hidden. And this distinction matters a lot because giving fluid restriction to hypovolemic patients can actually worsen the problem. In this case example, bedside Doppler assessment showed low stroke volume with a positive passive leg raise response, suggesting fluid responsiveness. And after cautious fluid administration, both serum sodium and hemodynamic improved, confirming that the patient was actually volume depleted from the start. Now, there are several ultrasound findings that can support hypovolemia. For example, predominant lines, as we mentioned, online ultrasound suggest absence of pulmonary congestion. A reduced LVO2 stroke volume may indicate low forward flow, and highly collapsible inferior vena cava can support low intravascular volume status. So this is a perfect example for how POCUS can uncover physiology that may not be obvious for standard bedside examination alone. And honestly, this is where modern bedside ultrasonography becomes incredibly powerful, especially in complex hyponatremia cases where the clinical picture is mixed or misleading in some circumstances. So after discussing the individual tools, the next step is integrating everything into a structured diagnostic approach. Modern hyponatremia evaluation is increasingly moved toward that we call phenotypic or phenotypic classification, meaning instead of relying on a single lab value or isolated physical finding, we combine clinical phenotype, hemodynamics, and lab data and imaging information to define the underlying physiological pattern. The first step is always confirming that this is truly hyponatremic, hypotonic hyponatremia. After that, we assess symptom severity and determine whether urgent intervention is needed or not. Then we move into physiological classifications, hypovolemic versus euvolemic or hypovolemic phenotypes. At this stage, urine osmolality, urinary sodium, and medications review, endocrine evaluation, and increasingly POCUS findings all become integrated into a decision-making process. And honestly, this multi-dimensional approach is probably much closer to real clinical practice than the old rigid textbook algorithm, because many patients doesn't fit perfectly into one classic category. You may have mixed physiology, overlapping mechanism, diuretic exposure, CKD, heart failure, liver disease, or occult hypovolemia all at the same time. And this is exactly why phenotypic classifications and bedside physiological assessments are becoming central concepts in modern hyponatremia diagnosis. So, practically speaking, how do we approach a patient with hyponatremia in a systemically way? A useful framework is to move step by step through the physiology. First, confirm that this true hyponatremia is actually present and determine whether this is hypotonic hyponatremia, because not every low sodium value represents a true hypotonic disease. You always have to think about pseudo-hyponatremias or translocational causes first. The next step is assessing urine osmolality. This tells us whether the kidneys appropriately suppressing EVP and excreting free water, or whether EVP activity is still present. After that, we measure urinary sodium. This helps us understand whether the kidneys are conserving sodium appropriately, or whether there is renal sodium wasting or SIADH type physiology. And then increasingly, we integrate POCUS assessment for congestion and hemodynamic measurement, because combining lab data and real-time bedside physiological assessment often gives a much more accurate picture of effective circulating volume. This sequential approach reflects real-world clinical practice much better than the other old one. The goal is not just labeling the patient as hypo, EU, or hypovolemic, and the real goal is understanding the dominant physiological mechanism driving this hyponatremia. Acute symptomatic hyponatremia should always be treated as true medical emergency, because at this stage, the immediate threat is cerebral edema and neurological deterioration. So the priority is not full normalizing of sodium. The initial goal is simply to raise serum sodium enough to reverse life-threatening brain swelling. Current guidelines recommend giving 150 millimeters of 3% hypertonic saline over about 20 minutes. After that, serum sodium should be reassessed. And if severe symptoms persist, the bolus can be repeated, usually up to 2 additional times, aiming for an initial rise of roughly 4 to 6 millimoles per liter. That early correction is often enough to significantly reduce intracranial pressure and stabilize neurological symptoms. But this is where careful monitoring becomes absolutely essential, because once the patient starts improving, the danger can quick shift from undercorrection to overcorrection. And this risk becomes very high if the patient has hyperkalemia, hypovolemia, alcoholism, malnutrition, chronic hyponatremia. So these patients require close biochemical clinical monitoring, often with sodium checks every couple of hours during active correction. And honestly, management of severe hyponatremia is really a balance between two neurological catastrophes: cerebral edema on one side and osmotic demyelination on the other hand. One extremely important concept in hyponatremia management is the impact of hypokalemia. And honestly, this is one of the most underestimated causes of unintentional overcorrection. Potassium replacement itself can raise serum sodium. Why? Because when potassium enters the cell, sodium and hydrogen ions shift out of the intracellular space, effectively increasing serum sodium concentration. So, in practical terms, potassium acts almost like an osmol during correction. And this becomes especially dangerous when potassium chloride is being administered alongside hypertonic saline, because the sodium may start rising much faster than expected. There is another issue as well. Once hypovolemia and hypokalemia begin correcting, EVP levels may suddenly fall, leading to risk-free water diuresis. And that can rapidly accelerate sodium correction even further. And this is exactly where the risk of ODS becomes very real. So whenever you see a hyponatremic patient with hypokalemia, you should immediately think this patient is high risk for overcorrection. And these patients require extreme close monitoring, often with serum sodium checks every 2 hours during the active treatment. And in severe chronic hyponatremia, especially with sodium below 120, slower and more controlled overcorrection strategies are usually much safer than aggressive normalization. One of the most important principles in hyponatremia treatment is that the goal is controlled correction, not rapid normalization, as we mentioned. In the first 2 hours, especially in acute or severely symptomatic hyponatremia, we usually aim for initial sodium rise of about 4 to 6 milliosmoles per liter. That amount is often enough to significantly improve cerebral edema and stabilize neurological symptoms. But after that early phase, caution becomes extremely important. In general, over the first 24 hours, correction should usually remain below about 8 millimoles per liter. Some older recommendations allowed 10 to 12 millimoles per liter in selected low-risk patients, but modern practice has become increasingly conservative because of concern about osmotic demyelination. And over 48 hours, total correction should generally never exceed 18 millimoles per liter, because the risk of ODS raised substantially beyond that threshold. Now, some patients are particularly high risk and require even stricter targets. This includes patients with alcoholism, malnutrition, advanced liver disease, hypokalemia, and profound chronic hyponatremia, as we mentioned. In these patients, many experience aims for no more than 6 to 8 millismoles per liter per day, and sometimes even less. So really, successful hyponatremia management is not about how fast you can correct sodium. It's about correcting it safely while continuously anticipating changes in physiology. This is a complication we fear most when correcting chronic hyponatremia too rapidly. ODS. In chronic hyponatremia, the brain gradually adapts to the hypotonic event. To protect itself from cerebral edema, brain cells start losing organic osmolytes, such as taurine, myo-inositol, and creatinine. That adaptation helps maintain cell volume and prevent excessive swelling. The problem happens when serum sodium is corrected too quickly. A rapid rise in extracellular tonicity suddenly reverses the osmotic gradient. Water rapidly leaves brain cells before they can reaccumulate osmolytes. The result is steroid dehydration and injury, especially affecting oligodendrocytes and myelin integrity. This leads to demyelination, especially in the bones. But extrapontine regions can also be involved. Pathophysiology, astrocyte dysfunction, and impaired metabolic support to oligodendrocytes may play a major role in this process. Clinically, patients may initially appear improved. then deteriorates several days later with dysarthria, dysphagia, and quadriparesis, behavioral changes, and even locked-in syndrome. This is exactly the way we emphasize controlled correction targets, particularly in chronic hyponatremia and in high-risk patients, because once ODS develops, treatment options are extremely limited, and prevention remains the key strategy in all these settings. For many years, the traditional teaching in hyponatremia management has been avoid rapid correction at all costs because the fear of osmotic demyelination syndrome. However, more recent observational data have started to challenge that very rigid concept. A large meta-analysis by EOS and colleagues involving more than 11,000 patients suggested that faster correction defined as more than 8 to 10 within 24 hours was associated with lower in-hospital mortality, lower 30-day mortality, and shorter hospital stay. Importantly, this was not accompanied by a clear increase in ODS in those cohorts. But we have to interpret these findings very carefully. These studies are observational cohort studies, not randomized controlled. So there are important limitations, including selection bias and confounding factors. For example, patients who corrected faster may simply have had more reversible disease, better physiology, or better overall response to treatment. So at the present time, these findings don't justify abandoning current guidelines, recommendations, correction targets. Still, this evolving evidence teaches us as an important concept. Excessively slow correction may also be harmful in some patients, and this moves us toward a more individualized strategy rather than one-size-fits-all approach. In modern hyponatremia management, the goal is not simply slow correction. The goal is controlled, monitored, and patient-specific management. In many hospitals, especially resource-limited setting, ready-made 3% hypertonic saline may not always be available. And these situations can be swiftly prepared using concentrated sodium chloride solutions, commonly 70.7% sodium chloride. And the preparation follows the standard dilution principle. The formula calculates how much concentrated solution is needed to achieve the desired final concentration after dilution with a normal saline. For example, to prepare 1 liter of 3% saline, we use 125 millimeters of 17.7% sodium chloride together with 875 millimeters of 0.9% saline. That corresponds to approximately 12.5 ampoules if each ampoule contains 10 millimeters. Similarly, to prepare 500 millimeters of 3% saline, we use 62.5 millimeters of 17.7% sodium chloride with 437.5 millimeters of normal saline. One very important practical point before adding the concentrated sodium chloride, an equivalent volume must first be removed from the base solution bag. Otherwise, the final sodium concentrations will be lower than intended. And of course, once hypertonic saline is started, careful monitoring is mandatory. Serum sodium should be checked frequently, especially in patients with high risk of overcorrection or ODS, as we mentioned. Before labeling a patient as having true hypotonic hyponatremia, we must first exclude pseudo or hyponatremia or another entity translocational causes, because not every low sodium values reflect true sodium deficiencies or excess body water. And pseudo-hyponatremia, the measured serum sodium appears low, but plasma tonicity is actually normal. This actually happens because of marked expansion of non-aqueous phase of plasma, especially lipids or proteins. Classic cause increase severe hypertriglyceridemia, hypercholesteremia, or marked hyperparaproteinemias. Intravenous immunoglobulin or therapy can be a cause, and even monoclonal gammopathies such as multiple myeloma. The sodium concentration within plasma water is actually normal. The problem is mainly a lab measurement artifact, especially with indirect ion selective electrolysis techniques. Another important category is hypertonic hyponatremia. Here, osmotically active substances like glucose pull water from intracellular to extracellular space, diluting serum sodium. Again, this is not true sodium depletion. And this distinction is critically important clinically, because treating these patients with hypertonic saline regressive sodium replacement may be completely inappropriate. The correct management is treat of the underlying disorders, such as correcting hyperglycemia or measurement the lipid or protein abnormalities. So whenever you see hyponatremia, the first question should not be simply what is the sodium level. The first question should be what is the serum tonicity of this patient. In chronic euvolemic hyponatremia, particularly SIADH fluid restriction remains the traditional first-line therapy. The principle is straightforward: reduce free water intake below the kidney's impaired excretory capacity, allowing gradually correction of serum sodium. Most guidelines recommend restriction to around 800 to 1 liter per day. It's simple, inexpensive, and generally safe, which explains why it continues to be widely recommended. However, in real-world practice, the response is often disappointing. Studies show that approximately 40 to 50% of patients fail to achieve meaningful sodium correction with fluid restriction alone. And adherence itself can be extremely difficult, especially in patients with intense thirst-driven biopersistent AVP activity. Randomized controlled trial evaluating restriction to 1 liters per day demonstrated a modest median sodium increase of about 3 millimoles per liter after 3 days, with a little additional improvement by 30 days. So while fluid restriction remains an important foundational strategy, clinicians should be recognized its limitations. Patients with highly concentrated urine, elevated urine osmolality, or high urine sodium are less likely to respond adequately because their kidneys continues retaining free water very efficiently. This is why newer strategies, including Urea, vasopressin antagonist, and combination approaches, are increasingly being explored in refractory cases. One major challenge in site management is predicting which patients are actually going to respond to fluid restriction. And this is where the Furst equation becomes clinically useful. This equation is very simple: urine sodium plus urine potassium divided by plasma sodium. This provides a practical besides estimate of electrolyte free water clearance and help predict whether fluid restriction is likely to work. When the ratio is less than 0.5, the urine is relatively dilute. These patients usually respond well to moderate fluid restrictions, typically about around 800 to 1 liters per day. When the ratio falls between 0.5 to 1, response becomes intermediate and less predictable. These patients may require stricter fluid restriction, sometimes around 500 millimeters per day, together with close monitoring. But when the ratio exceeds 1, the urine is highly concentrated, reflecting persistent AVP activity and minimal free water excretion. In these patients, fluid restriction alone have very low probability of success. And this is a very important clinical point because many patients are kept on prolonged ineffective fluid restriction despite physiological evidence that is unlikely to work. So high first index should prompt early consideration of a second-line therapy such as Urea or vasopressin receptor antagonist, depending on the clinical setting and contraindications. This equation essentially transforms fluid restriction from an empirical strategy into a more physiologically guided approach. Although the first equation is very practical, it's important to understand that it is not perfect. Several studies have evaluated its predictive performance, and while useful, its accuracy remains moderate rather than absolute. For example, a study done suggests that cutoff around 0.86 identified likely non-responders to fluid restriction. However, the overall discrepancy performance remained modest, with an area under curve of approximately 0.65. So this means this equation should guide clinical reasoning, not replace clinical judgment tool. The first equation performs best as part of integrated physiological assessment that includes urine osmolality, urine sodium volume status, and the overall clinical context. Another complementary concept is the electrolyte-free water clearance. This expands the physiological interpretation even further. The formula estimates whether the kidney is excreting or retaining free water relative to plasma composition. When electrolyte-free water cleans strong positive, particularly above 500 to 800 millimeters per day, patients are more likely to respond favorably to fluid restriction. But when values become very low or even negative, it suggests ongoing free water retention and a high likelihood that adjunctive therapies may be needed. And this is really the broader message of modern hyponatremia management. We are gradually moving away from purely descriptive approaches toward physiological-based prediction tools that help individualize therapies and anticipate treatment response more accurately. When fluid restriction fails, two important second-line options commonly discussed are vasopressin receptor antagonists, particularly Vaptan and oral Urea. Both aim to increase free water excretion, but they differ significantly in physiology, safety profile, and cost and practicality. Starting with Vaptans, Vaptan blocks CV2 vasopressin receptor in the collecting duct, producing aquaresis, meaning excretion of electrolyte-free water. This often results in relatively rapid rise in serum sodium. In comparative studies, sodium increased by approximately 5 millimoles per liter within 12 hours. substantially faster than with urea. However, this rapid effect comes with an important downside, a much higher risk of overcorrection. Some studies report overcorrection rates approaching 40% or more, compared with much lower rates using urea. And because of that, Vaptan requires very close monitoring, especially during the first 24 hours. And it's also expensive and may not be available in many countries. Now looking at urea, urea works differently. It increases osmotic solute excretion, enhancing free water clearance in a more gradual and physiological way. The sodium rise tends to be slower and more controlled, which significantly reduces overcorrection risk. Importantly, multiple research suggests that urea may achieve comparable overall efficacy to Vaptans in chronic SIADH, but with better safety and lower cost. Typically, doses range around 15 to 30 grams daily, often divided into 2 doses. And in many modern nephrology practice, urea is increasingly favored because of its safety profile, availability, and predictable correction patterns. So clinically, the choice often comes down to balancing speed versus control. Tolvaptan may achieve faster correction, but urea usually offers a safer and more controlled trajectory. Now, after discussing the potential benefits of Vaptans, an important clinical question comes up. Why are Vaptans still not considered first-line therapy in most guidelines? The answer is mainly related to outcomes and safety and practicality. First, although Vaptans reliably increase serum sodium, randomized studies have not consistently demonstrated improvement in hard clinical outcomes such as mortality, quality of life, and long-term neurological benefit. In other words, we improve the lab number, but translating that into meaningful patient-centered outcomes remains less clear. Second, cost is a major limitation. Tolvaptan is expensive, very expensive, and especially for prolonged use, making routine use impractical in many healthcare systems. Third, and probably most important clinical point, there is substantial risk of overcorrection. Even in relative low doses, rapid aquaresis can cause sudden sodium rise, particularly in patients with very concentrated urine or reversible SIADH triggers. And as we discussed earlier, overcorrection raises concern for osmotic demyelination syndrome. Another issue is that the long-term safety profile in mild to moderate chronic hyponatremia is still not fully established. Because of all of concerns, most current guidelines reserve Vaptans for carefully selected patients, typically after failure of conservative measures like fluid restriction and only under close biochemical monitoring. So practically speaking, Vaptans are powerful tools, but not routine first-line therapy as we mentioned. Now let's talk about treatment that's becoming increasingly appreciated in modern hyponatremia management, and that is urea. For many years, urea were overlooked, partly because newer agents like Vaptans attracted more attention. But interestingly, many experts now consider urea one of the most practical and safest therapies for chronic SIADH. So why does urea work? Essentially, urea acts through osmotic diuresis. It increases renal solute excretion, which enhances electrolyte-free water clearance, allowing gradual removal of excess-free water, slow overcorrection of serum sodium, and that gradual correction is extremely important because it lowers the risk of rapid overcorrection and osmotic demyelination syndrome. Now, from a practical standpoint, urea has several advantages. It's relatively safe, cheap, widely available, and generally associated with minimal adverse effects. Unlike Vaptans, the sodium rise is usually more controlled and predictable. Clinical urea is commonly administered as an oral powder dissolved in water or juice, with usual dose about 15 to 30 grams per day. Of course, the major limitation is palatability. Many patients like the taste, although flavored formulations have improved tolerability significantly. This slide also highlights an important historical point. Older therapies like democycline lithium are now rarely used because of toxicity profile, particularly nephrotoxicity. And the low diuretics combined with isotonic saline are usually reserved for hypovolemic states rather than classic euvolemic SIADH. So overall, urea offers something very attractive: simple, low cost, controlled, and relatively safe strategy for chronic hyponatremia management. Now, this is one of the most important modern concepts in hyponatremia management, the use of desmopressin or DDAVP to control sodium correction. At first glance, this idea sounds paradoxical. We are treating hyponatremia, we are intentionally give an ADH analog. But the goal here is not to worsen hyponatremia. The goal is to prevent uncontrolled overcorrection. Remember, the major danger in chronic hyponatremia is not the low sodium itself, but correcting it too rapid. And that rapid use rise usually happens when patient suddenly develops a larger free water diuresis, especially after volume restoration, stopping metabolites, resolving SIADH triggers, or correcting hypovolemia. DDAVP acts like a brake, stabilizes water handling, reduces sudden aquaresis, and creates a more predictable sodium correction curve. Now, clinically, there are three major strategies. First, the proactive one. Here, the DDAVP started earlier in high-risk patients, often together with hypertonic saline, to tightly control the correction trajectory from the beginning. This approach creates a very predictable sodium curve. Second, the reactive strategy, which is probably the most common in practice. In this approach, the DDAVP is administered once clinician notices unexpectedly brisk sodium rise, high urine output, or sudden drop in urine osmolality. The goal is to stop the acceleration before correction limits are exceeded. Third, the rescue strategy. This is used after sodium correction has already exceeded thresholds. DDAVP is combined with free water replacement, usually D5 water, so to intentionally lower sodium levels and reduce OD risk. So overall, DDAVP has fundamentally changed how many experts manage severe chronic hyponatremia. And instead of passively watching sodium rise, we can now actively control the over-correction process much more safely. Building on the concept of DDAVP as a brake, these slides introduce what many clinicians now call the DDAVP clamp strategy. The idea is actually very elegant, and instead of waiting for unpredictable water diuresis to occur, we intentionally clamp the kidney's water handling with scheduled DDAVP while simultaneously controlling sodium rise using hypertonic saline. In other words, we remove the variability. This approach became popular after observational studies and quality improvement series, including the work by Sood and colleagues, showed that combining scheduled DDAVP with hypertonic saline produces a very steady, controlled sodium correction, typically around 5 to 6 millimole per liter over 24 hours, without excessive overcorrection or ODS. And this is particularly valuable in critically ill patients, very high-risk patients, such as profound chronic hyponatremia, alcoholism, malnutrition, hypokalemia, or even liver disease. Now, regarding practical regimen, DDAVP is commonly administered as 1 to 2 mic IV or sub-Q every 6 to 8 hours, or intranasally, typically 10 to 20 micrograms every 8 to 12 hours. And importantly, if overcorrection still occurs, DDAVP can be combined with IV dextrose 5% to intentionally lower sodium safely. Now, despite growing enthusiasm, it's important to remember that most evidence supporting the DDAVP clamp strategy remains observational. We still need prospective RCTs to determine the optimal timing, dosing, and the long-term clinical impact of these. But practically speaking, many nephrologists and endocrinologists now consider the DDAVP clamp one of the safest approaches to managing severe chronic hyponatremia at high risk for overcorrection. Now, despite fluid restriction, not all patients with euvolemic hyponatremia respond adequately, and this is especially common in persistent SIADH, where urine remains highly concentrated and free water excretion stays limited. So in refractory cases, we often need additional strategies to increase solute excretion or enhance free water clearance. The first option is oral salt tablets. By increasing solute intake, salt tablets can improve electrolyte-free water excretion, particularly when fluid restriction alone is insufficient. However, salt alone may not work well if the kidney still retains water aggressively under ADH effect. This is why some clinicians combine oral sodium with low-dose loop diuretics such as furosemide. Loop diuretics reduce metabolic concentration gradients, making the kidney less able to concentrate urine, which promotes excretion of electrolyte-free water. Essentially, they convert concentrated urine into a more dilute urine. Another increasingly discussed approach is the high protein intake. Higher protein intake increasing the endogenous urea generation, which act as an osmotic agents and enhance water excretion naturally. This is one reason why low solute diets can worsen chronic hyponatremia, particularly in elderly patients with poor nutritional intake, like toast and tea diets. Now, an important practical message here is that all these interventions require careful monitoring, because once ADH effects suddenly decrease or solute intake becomes excessive, patients may rapidly overcorrect. And excessive loop diuresis can also cause volume depletion or electrolyte disturbances. So overall, management of refractory euvolemic hyponatremia is really about manipulating renal water handling carefully, while continuously monitoring sodium trajectory and urine output of these patients. Now, another therapy occasionally discussed in hyponatremia management is Fludrocortisone, but its role is actually much narrower than many people think. It's a mineral corticoid, so physiologically enhance sodium reabsorption in the distal nephron, promoting sodium retention and volume expansion. The strongest evidence supporting its use comes mainly from patients with cerebral salt wasting, particularly after subarachnoid hemorrhage. As shown here, some RCTs demonstrated that fludrocortisone, typically a dose around 0.1 to 0.4 milligrams daily, can shorten the time needed for sodium normalization in these patients. But the key point is this: that benefit applies mainly to true renal salt wasting states. It's very important not to confuse cerebral salt wasting with SIADH, because both may present with hyponatremia and high urine sodium, and their physiology is completely different. Inside, the problem is excess water retention, not sodium wasting, so giving fludrocortisone inside usually offers little benefit, and may worsen hypertension, fluid overload, or even the hypokalemia. That's why current European guidelines generally restrict fludrocortisone use to carefully selected cases of CSW, and don't recommend it routinely for euvolemic or hypovolemic hyponatremia. So practically, fludrocortisone remains a therapy useful in right physiological setting, but definitely not a true routine treatment for most hyponatremic patients. Now let's put everything together into a practical treatment framework based on the underlying etiology of hyponatremia, starting with euvolemic hyponatremia, especially SIADH. The cornerstone of first-line therapy remains fluid restriction, typically around 800 to 1 liters per day. Patients fail to respond. Second-line options include oral urea, which is increasingly favored because of safety profile, predictable correction profiles, while Vaptans are generally reserved for carefully selected cases. For hypovolemic hyponatremia, the treatment is fundamentally different. Here, the problem is sodium and volume depletion, so isotonic saline volume depletion is the primary therapy, while simultaneously correcting the underlying trigger, such as GI losses, diuretics, or adrenal insufficiency. Going to hypervolemic hyponatremia, like heart failure or cirrhosis, management focus mainly on treating the underlying disease process, combined with low diuretics and fluid restriction. Vaptans may occasionally be considered in selected refractory patients, but again, not routinely. And for cerebral salt wasting, the physiology is through renal sodium loss, so treatment requires both volume and salt replacement. In refractory situations, fludrocortisone, sometimes combined with hypertonic saline, may help reduce ongoing natriuresis. And finally, acute symptomatic hyponatremia is always treated as medical emergency. Here, 3% hypertonic saline boluses, typically 150, repeated 1 to 3 times, are used to rapidly achieve modest but life-saving rise in serum sodium. At the same time, careful monitoring is essential to avoid overcorrection, and this is where strategies such as the DDAVP clamp may become extremely valuable. So the most important message from this slide is hyponatremia treatment is never one size fits all. The correct therapy depends entirely on understanding the underlying physiology and volume status of the patient. This is one of the most challenging and controversial areas in hyponatremia. Cerebral salt wasting and SIADH can look remarkably similar at the first instance. Both typically present with hyponatremia, high urinary sodium, and inappropriately elevated urine osmolality. So at first glance, the biochemical profile may appear almost identical. But the critical difference lies in the effective circulating volume status. And because of that, the treatment approach becomes completely opposite. In SIADH, patients usually euvolemic and even mild hypervolemic. The main problem is inappropriately water retention driven by excess ADH activity. On the other hand, in cerebral salt wasting, the primary issue is renal sodium loss, leading to true volume depletion. And this distinction matters enormously because giving fluid restriction to a patient with cerebral salt wasting may actually worsen hypovolemia and cerebral perfusion, while aggressive saline administration inside can aggravate hyponatremia more and more. Unfortunately, current guidelines acknowledge that no single clinical or biochemical marker reliably differentiate by two entities. Even markers like serum uric acid, fractional excretion of urate, natriuretic peptides have limited specificity and may overlap considerably. So, in real-world practice, the diagnosis often depends on carefully longitudinal assessment of volume states of the patient, hemodynamics, urine output, response to saline, and overall clinical trajectory. This is why many experts consider the distinction between SIADH and CSW less of single lab diagnosis and more of dynamic clinical interpretation between all of these. This slide summarizes the potential difference between three entities that may all present with chronic hyponatremia but behave very differentially physiologically. Starting with SIADH, patients are typically euvolemic, plasma sodium is low, urine remains inappropriately concentrated, and saline infusion often fails to improve sodium because of what's known as desalination. And may even worse because the kidney continues retaining free water. A very important clue is fractional excretion of uric acid in SIADH. It's usually elevated during hyponatremia, but tends to normalize after sodium correction. Treatment mainly relies on fluid restriction, and in refractory cases, urea or occasionally Vaptans. Now compare that with cerebral salt wasting. Here the patient is actually hypovolemic due to true renal sodium loss. Urine sodium is high, urine osmolality is elevated, but unlike SIADH, the patient typically improves with saline and volume replacement. Another useful clue is that fractional excretion of uric acid often remains elevated even after sodium correction, reflecting persistent renal salt wasting. Treatment therefore is completely different, focusing on volume and salt replacement, sometimes with Fludrocortisone support, as we mentioned. And finally, reset osmostate is a second and often under-recognized condition. These patients have a downward resetting of the osmotic threshold for ADH release. So sodium is mildly low but remarkably stable, usually without a progressive decline. Importantly, the kidney still preserve normal urinary dilution capacity, which differentiates reset osmostate from classic SIADH. Patients are usually clinically euvolemic, and aggressive attempts to normalize sodium may actually provoke overcorrection or unnecessary complications. So in many cases, the best management is simply observation and avoiding overtreatment. The key takeaway is the identical sodium values don't necessarily reflect identical physiology. Understanding these underlying mechanisms is what determines the correct treatment strategy. Reset osmosis is an important but frequently overlooked cause of chronic mild hyponatremia. In this condition, the hypothalamic threshold for vasopressin release becomes chronically shifted downward. As a result, the body establishes a new steady state of sodium concentration at lower levels, as we mentioned. So unlike classic SIADH, the patient is not progressively retaining water uncontrollably. Instead, the system is relatively stable, just reset to operate around lower plasma sodium concentration. Clinically, these patients are usually euvolemic, often asymptomatic. Sodium levels tend to remain chronically low and mild and stable over time. One of the most important concepts is preserved urinary dilution capacity. This is actually the diagnostic hallmark. In the classic water loading test, the patient with reset osmostatin are able to excrete more than 80% of free water load, which indicates that the kidney can still appropriately suppress ADH when needed. In contrast, patients with true SIADH usually have impaired free water excretion. Another useful practical clue is fractional excretion of uric acid. Values below 11% may favor reset osmostate, where persistent elevation is more typical of SIADH or cerebral salt wasting. Why does this matters clinically? Because recognizing reset osmostate prevents unnecessary and potentially harmful interventions. These patients often don't need aggressive fluid restriction, Vaptans, or repeated attempts to normalize sodium. In fact, forcing sodium upward may provoke overcorrection without meaningful clinical benefit. And interestingly, many experts now believe that SIADH, cerebral salt wasting, and reset osmostate may not always represent a completely separate diseases, but rather points along a physiological continuum of disturbed water and sodium dysregulation. Sometimes the clinical context itself gives important clues before lab interpretation even begins. For SIADH, the classic association are pulmonary disease, central nervous system disorders, medications, malignancies, especially small cell lung carcinoma. So whenever you see unexplained euvolemic hyponatremia in a patient with pneumonia, stroke, meningitis, antidepressant use, or small cell lung cancer, SIADH may be very high on your differential diagnosis list. Now compare that with cerebral salt wasting. It's more strongly linked to acute neurological injury. Typical settings include subarachnoid hemorrhage, traumatic brain injury, neurosurgery, or severe CNS inflammation. These patients often have high urinary sodium, large urine output, progressive volume depletion despite ongoing saline administration. And then we have reset osmostate, which usually appears in more chronic adaptive physiological states, typically associated with elderly patients, pregnancy, chronic systemic illness, TB, and occasionally malignancy. Here, the body appears to adapt to chronically lower sodium set point while maintaining relatively stable osmotic regulation. So although lab overlap is common, the surrounding clinical scenario often provides a major diagnostic clues. And in many cases, understanding the underlying disease context is just as important as interpreting the sodium value itself. So as we move toward the conclusion, they may be one of the most important messages from the entire talk. A serum sodium below 135 is never just a number. It's often only a visible surface of much deeper physiological disturbance. Behind that sodium value, there are maybe abnormalities in water handling, effective circulating volume, solute balance, renal adaptation, or neurohormonal regulation. And this is exactly why hyponatremia can become so challenging, especially in refractory cases, critically ill patients, low resource setting where advanced testing may not otherwise be available. Over the last years, our understanding has evolved significantly. We are no longer relying only on isolated sodium measurement. Advanced neural induces point-of-care ultrasound, free water clearance concepts, and newer physiology models have refined how we approach diagnosis and treatment. But despite all these advances, clinical reasoning remains central because ultimately the sodium value itself is not the disease, it's a signal pointing toward an underlying physiology process that must be understood in the context. The second major takeaway is that our approach to volume assessment in hyponatremia needs to evolve. Traditionally, we relied heavily on bedside clinical examination alone, trying to classify patients as hypovolemic, euvolemic, hypervolemic based on physical signs alone. But in reality, this approach has important limitations. As we mentioned, edema, mucous membranes, secondary or jugular venous pressure can often be misleading, especially in elderly patients, critically ill patients, or complex cardiorenal states. And multiple studies showing that agreement between clinicians on volume assessment is actually quite poor. This is why modern hyponatremia evaluation increasingly incorporates point-of-care POCUS and should not be viewed as replacing clinical examination, but rather an extension of it. It provides dynamic, real-time, and reproducible information about intravascular volume, status, and congestion. For example, lung ultrasound, IVC assessment, venous Doppler patterns, and focused cardiac ultrasound can help distinguish congestion from true volume depletion far more accurately rather than physical examination. And this becomes particularly important because treatment decisions in hyponatremia depend heavily on correct volume interpretation. A mistaken volume assessment may lead to exactly wrong therapy. So perhaps in future, hyponatremia diagnosis is not simply better lab tests, but smarter integration of physiology, clinical reasoning, and bedside imaging together. The third key takeaway is that treatment of hyponatremia should follow rational therapeutic steps, not a random escalation of therapies. The first step, particularly in chronic euvolemic hyponatremia, remains fluid restriction. It's still considered the cornerstone of initial therapy, mainly because it's simple, safe, widely available, and physiologically logical. But we also learned an important limitation. Not every patient responds equally to fluid restriction, and this is where the so-called Furst Equation becomes clinically very important and crucial. By looking at the relationship between urinary electrolytes and plasma sodium, we can anticipate whether fluid restriction is likely to work before wasting several days in ineffective therapy. If the patient is predicted to fail fluid restriction, we should think early about escalation strategies, and among these options, Urea DDAVP-based strategies are increasingly gaining attention, as we said. Urea is inexpensive, widely available, provides gradual control correction with relatively low risk of overcorrection. Meanwhile, the DDAVP has become an essential safety tool, particularly in preventing or reversing rapid sodium correction. This strategy represents a major shift. Instead of reacting to overcorrection after it occurs, we proactively control the sodium trajectory from the beginning. Finally, Vaptans, as we mentioned, should not be viewed as first-line agents. Although they can raise sodium effectively, their use should remain restricted to carefully select patients under close biochemical monitoring, mainly because of cost, overcorrection risk, and lack of clear improvement in heart clinical outcomes. So overall, modern hyponatremia therapy is becoming more individualized, more physiology-driven, and increasingly focused on safety rather than simply correcting a solid number. One of the most important messages in modern hyponatremia management is that our diagnostic toolkit is evolving rapidly. Traditionally, our approach relied heavily on few classic parameters: urine osmolality, urine sodium, physical examinations, or biochemical ratios like BON and creatinine. While these tools remain important, we now recognize their limitation, especially in critically ill patients, elderly patients, and complex mixed volume states. For example, clinical assessment of volume states alone can often be inaccurate, even among experienced clinicians. This is why newer approaches are emerging. Biomarkers like cobeptin and MRPRO-NB are being explored to better characterize vasopressin activity and intravascular volume states. At the bedside, POCUS is becoming increasingly valuable. Combining long ultrasound VEXUS and focused cardiac echo can provide real-time physiological information that's often more reliable than static examination finding. We also discussed the role of predictive physiology-based tools such as Furst Equation, which can help to anticipate response to fluid restriction before escalation therapy. And perhaps most exciting, we are entering the era where the AI and decision support system may soon assist clinicians in integrating complex physiological data into individualized diagnostic pathways. So the field is very clearly shifting from simplistic sodium-centered approach toward a major integrated, dynamic, and physiologically driven understanding of hyponatremia. Before concluding, let's briefly revisit the fundamental physiology behind sodium and water balance, because understanding the mechanism is what makes hyponatremia clinically intuitive rather than just memorized algorithm. Everything begins with an imbalance, either through water excess, sodium loss, impaired free water secretion, and extracellular fluid osmolality becomes disrupted. Specialized hypothalamic osmoreceptors rapidly detect these osmotic changes, and in response to major defense mechanisms become activated: thirst, vasopressin release, and what we commonly call ADH. ADH is released from the posterior pituitary and act mainly on V2 receptors in the collecting duct. This stimulates the insertion of aquaporin 2 water challenge, allowing free water reabsorption back into circulation. Under physiological conditions, the system is highly adaptive and protective. But in many disease states, the response becomes inappropriate, persistent, or even exaggerated, and this is the core mechanism behind many forms of hyponatremia, especially SIADH. Eventually, when osmolality normalized, ADH excretion should be suppressed, water balance restored, and homeostasis established. So in many ways, hyponatremia is not simply a sodium disorder, it's fundamentally a disorder of water regulation, vasopressin physiology, and renal handling of free water. To simplify everything we discussed, hyponatremia can broadly be approached through three major physiological categories: hypovolemia, euvolemia, and hypervolemia hyponatremia. In hypovolemic hyponatremia, both sodium and water are lost, but sodium loss exceeds water loss. Common causes include GI loss, diuretics, especially thiazides, sweating, cerebral salt wasting. Clinically, these patients usually show signs of volume depletion, such as orthostatic hypotension, tachycardia, and dehydration. Urine sodium helps differentiate renal from extrarenal losses. In euvolemic hyponatremia, total body sodium remains relatively normal, but there is excess free water retention. This is classical physiology of SIADH. Patients usually don't appear overtly dehydrated or edematous, which make diagnosis more challenging. Common causes include pulmonary disease, CNS disorders, medications, psychological polydipsia, and hypothyroidism in some rare cases. Finally, in hypervolemic hyponatremia, both sodium and water increase, but water retention predominates. This occurs in conditions such as heart failure, cirrhosis, nephrotic syndrome. Clinically, patients develop edema, ascites, signs of fluid overload. So despite the complexity of modern biomarkers and advanced in physiology, the foundation still begins with one key question: what's the patient's effective circulating volume states? Because once the framework is clear, the diagnostic and therapeutic pathway becomes much more logic and structured. As our understanding of hyponatremia evolves, interest in biomarkers has expanded significantly. These biomarkers are not intended to completely replace traditional tools, but rather to complement them, especially in difficult or equivocal cases. One of the most studied biomarkers is cobeptin, we mentioned, released alongside vasopressin, making it an indirect marker of EVP activity. It tends to rise in hypovolemia, SIADH, and physiologically stressed states. However, the major limitation is wide biological variability, which reduces standalone diagnostic reliability. That said, when cobeptin is combined with urinary sodium measurement, it may help differentiate between SIADH from hypervolemic hyponatremia in selected setting. Another promising marker is MRPRO-NB because it reflects atrial stretch, intravascular filling. It may help differentiate hypovolemic from euvolemic states, particularly when clinical examination is under appreciated or unclear. Some studies suggest that combining MR pro-NP with serum sodium may also improve prognostic reassessment, including short-term mortality and prediction. In contrast, NT-proBNP, although very useful in heart failure, has shown limited utility for differentiating hyponatremia subtypes specifically. So the overall message: important biomarkers are promising, especially in complex patients where routine urine analysis clinical examination becomes inconclusive, but at the present time, they still require further validation before widespread incorporation to routine diagnostic algorithm. For now, they should be viewed as supportive tools, not replacement for careful physiological reassessment. One of the most critical aspects in hyponatremia management is not just correcting sodium, but correcting it safely, because in many situations the danger comes not from the hyponatremia itself, but from overly rapid correction, and the complication we fear most is osmotic demyelination syndrome. So let's sum up practical correction targets. To keep in mind, in acute symptomatic hyponatremia, particularly when seizures, coma, or severe neurological symptoms are present, the immediate goal during the first few hours is modest improvement, not normalization. A rise about 4 to 6 millimoles is usually sufficient to stabilize cerebral edema and improve symptoms. After the initial phase, this emphasis shifts towards controlled correction. And in most patients, the acceptable correction limit is generally around 10 to 12 within the first 24 hours. However, many experts now prefer even more conservative targets, and regardless of circumstances, the absolute upper limits over 48 hours should not exceed approximately 18 millimoles per liter. Now, for very high-risk patients who must be especially careful, this includes patients with alcoholism, malnutrition, advanced liver disease, hypokalemia, profound chronic hyponatremia. In these patients, their common targets becomes much lower, typically around 4 to 6 millimoles per liter per 24 hours, with an upper limit of about 6 to 8. And this is exactly where strategies like DDAVP clamp protocols become extremely valuable, because they may help prevent unpredictable water diuresis and dangerous overcorrection that could happen. So the key principle is simple: in hyponatremia, slow and controlled correction is usually safer than rapid normalization. So when we're dealing with refractory hyponatremia, the key is to approach management stepwise rather than jumping immediately to aggressive therapies. The first line is, particularly in chronic euvolemic hyponatremia, remains fluid restriction. But if sodium fails to improve or if the patient is unlikely to respond, we should reassess physiology rather than simple tightening restriction blindly. This is where the first index becomes clinically useful. By evaluating the relationship between urinary electrolytes and plasma sodium, we can estimate whether free water restriction is likely to succeed. If the index suggests poor response, or if the patient already failed fluid restriction, then escalating becomes reasonably. At this stage, urea is increasingly favored as practical second-line therapy. It promotes osmotic diuresis along with gradual sodium correction and generally carries lower overcorrection risk compared with Vaptans. Typical dose range from 15 to 30 grams daily, adjusted according to response and tolerance and palatability. Now, if urea fails, cannot be tolerated, or if the clinical situation requires another strategy, Vaptans may be considered in carefully selected patients. However, the use should remain individualized with close sodium monitoring because of the risk of rapid correction. And throughout all these steps, and therapeutic decision should always balance several factors: the speed of correction needed, the patient ODS risk, and the cost, availability, and the overall clinical context. So ultimately, modern hyponatremia management is becoming less protocol-driven and more personalized and physiology-based. Thank you so much for watching. I hope this was a very detailed lecture, and I will see you inshallah in the next lectures. Assalamu alaikum wa rahmatullahi wa barakatuh.